It looks like many people have joined the room, so I want to welcome everyone to the CSNK2A1 Researcher Panel discussion. My name is Jennifer Sills. I'm the CSNK2A1 President and Founder. And joining us today is Dr. Wendy Chung, the Director of Clinical Research at SFARI and at Simon Searchlight, Dr. Heike Rebholz from the Institute of Psychiatry and Neuroscience at the University de Paris, Dr. Isabel Dominguez from Boston University School of Medicine, and Dr. Volkan Okur, clinical and laboratory geneticist at the New York Genome Center. Thank you so much for your interesting and thoughtful presentations. And for everyone listening in, you should be able to see and hear me on your screen. Although we won't be able to see or hear you, we welcome you to ask questions through the Q&A box below. And please remember to avoid including personal health information in your questions for your own privacy, as this is a recorded session. And we apologize in advance if we don't get to your questions. We will try to cover as many as possible. And with that said, let's start the Q&A discussion and hear from all of you. We'll begin with our first question that came in from France, which is, my son is 5 years old and says words and is starting to make sentences. Does that mean he will talk?
I guess I'll take that one, and if anyone else wants to chime in. So that's great. I think what we've the fact he's now starting to make words or make utterance, I think is a sign in terms of not only being able to understand, but going through the complex motions that are necessary, the lips, the teeth, the throat. Whoa, am I back? Okay, sorry about that. Anyway, great prognosis in terms of starting to make those words with the mouth. So I'd say I don't know exactly in terms of completeness, if it's full sentences, full paragraphs. I can't say exactly yet, but I think it's a great prognostic sign in terms of more verbal communication.
Fantastic, thank you. I know we have some members from the CSNK2B group here, and we had a question as to what is the difference between CSNK2A1 and CSNK2B?
I can take that question. CSNK2A1 and CSNK2B are two different genes, two different blueprints that are used to produce two different proteins that are what works in our bodies. These two proteins can work together in a larger complex that we call CK2. Is this clear enough?
Let me add one thing, which is that it might seem odd, given that you heard these are two different genes, but in the cell, the proteins work together. And so that's why we've thought that it might be helpful, given that each condition is individually rare. We think there's some utility, there's some force in numbers and being able to put it together since they're part of the same complex. There are some differences clinically between the two conditions. And so that's why we've have a breakout session right after this, so that we'll have time for the CSNK2B1 families to be able to come together, because some of the things I was saying earlier about Okur Chung syndrome, there's some things that are really specific more to that, and we wanted to make sure that you had time to understand your condition specifically better.
The next question is regarding Simon's Searchlight and donating blood. Is it possible for European families to donate blood for research?
So this is a good question, and I'll try and explain what the issues have been. So with COVID, we've been having issues with international samples of biological fluids, so blood samples specifically. And I think it's in large part because of the customs when it comes to the border. They're quite concerned about anything that might be infectious and transmitting SARS-CoV-2 or the COVID virus around the world. So it's been extremely, extremely difficult because samples have been sitting in customs, and even when they're allowed to go through, by the time they get to their destination, the cells are not living. So right now, I hope COVID passes very soon. Right now, I don't think it's really feasible for us to get the samples from overseas to the United States in the shape that we want them. I will say we're very committed to our families in Europe and around the world. For sure, when we have the in-person meeting in August 2022, that is next year at this time, for those families who come to Baltimore, we will have the whole setup there to be able to draw and process the samples. I realize not all families will be able to come, but if you are able to, we'll definitely make sure anyone who's represented there is able to donate a sample. I do expect that once COVID lifts, whenever that is, we'll have additional solutions, whether it's initially shipping them from overseas to the United States, but doing it more quickly, or whether it's way stations. So you already may or may not appreciate that we've got France represented up here on our screen. So we've got way stations in Europe where we might be able to send things at least within Europe, for instance, and do some things, and then eventually under better circumstances be able to make transfers to the United States or wherever they need to go in the world. So we've got backup plans that we've been thinking of. We don't want to leave anyone behind, and it's only because of this very unusual situation with COVID that I think that we've got some temporary issues. But we hear you, and we want to make sure, as I said, that everyone has a chance to be represented.
The next question is regarding epilepsy and seizures. If someone has seizures, will they need lifetime treatment, or can it settle over time? Does it matter the type of seizures? For example, do you see absence seizures settle over time?
Maybe this else can answer if I'm in. So number one, thank you for everyone who's contributed information, because we're getting a better sense of this. Although I will say, as I was saying in my talk, that there's some limitations specifically around the age distribution of who we have. Thankfully, we do have folks that are teenagers and young adults. But the reason I bring this up in this context with seizures in particular is during adolescence, during puberty, and when many of the hormones are changing, we oftentimes see, not just with this condition, but across other neurogenetic conditions, that things can change with the seizures. So I'm particularly sensitive that I don't think know the full picture in terms of what happens with some of our kids that might have had, especially something like absence or sort of looking like zoning out, but these very short seizures, whether if they go away and are treated well with a single medication, if that's a lifelong thing, or whether something else could happen. There are other things that can make seizures worse in anyone. So head trauma in particular, if you bump your head hard, if there's an infection or encephalitis in the head, in the brain, then that can make things worse. So I think that's going to be true for us in general. And then, as I said, we're looking specifically to ages, puberty in particular, where things might change. I would say this is generally, I've said it before, but I'll say it again, this is not generally a degenerative course. So it's generally not the case that we're seeing like all of a sudden things get much worse when you hit 13 or things get much worse when you hit 21. That's generally not the course that we're seeing. And I do think that as we collectively get better about sharing information, kind of best practices, standards of care, so to speak, with this, that we will find better management in terms of the right either medication or medications for the epilepsy. There are certain people in the community, though, and I know you know this, where the seizures seizures are a big deal. And so I do think there's variability. Not every genetic variation, I think, behaves the same in terms of the seizures, the seriousness, the response to the medications. So there's going to be still some variability person to person within the community.
There are some questions regarding hypotonia. And it's kind of a two-part question. With neurodevelopmental disorders and hypotonia, does the muscle tone ever get better? Does it degenerate over time or stay the same? And the second part of the question is, what areas of the body internally can hypotonia affect? So for example, bowel or bladder or esophagus for swallowing.
I'll start with this and then anyone else can chime in. In terms internally, the major thing that we see is, I think of it as always related to the brain fundamentally, but the brain affects parts of the body that you might not expect it to. So it affects, for instance, muscles, muscles in the trunk, muscles in the arm and the legs. The hypotonia is always there. It never completely goes away. And it's something that we use therapy, the physical therapy, to build core strength in particular, to build strength, but the low tone is still an issue. Unless there are individuals that have such severe problems with epilepsy, they can actually develop some hypertonia or some sort of tightness in some of the muscles that the therapist have to help in terms of relaxing some of those. There are nerves from the brain and also inside the body, nerves that are going to other parts of the body, in particular the intestine. And so the hypotonia or the muscle, the intestine, is constantly going through what we call peristalsis, or muscle contraction that's moving things along in the intestine. And if it's not moving things along at just the right pace, it can either slow down and cause constipation, or it can go really fast and cause diarrhea. So it can do either of those in the same person, even in the same day. It can do both, depending on exactly what's going on. So again, even with the therapies, even, whether it's physical therapy or medications that are helping, even if there are diet or medications helping with constipation or diarrhea, it's not correcting the underlying problem with this muscle contraction or hypotonia in the intestine. So it's something that you can make better. I do want to give you some hope. Things can get better and do get better, but that fundamental problem is still there. With the bladder itself, I guess I haven't seen so much the hypotonia with that. I do think there are problems in terms of toileting and learning how to have a sense of urgency or when you need to go or things like that. And I think that's probably the bigger issue in terms of bladder control or bowel control for toileting and learning that. I know I'm going to also pick up a question someone else asked about growth hormone, if I can digress for a second. So growth hormone, I think the reason some people are asking is because many of the children are on the shorter side, they're more petite, and they're also skinnier. They may not gain weight as much. And so naturally, pediatric endocrinologists think to themselves, well, if you're short, maybe we can give you an injection of growth hormone that'll help you grow taller. Fundamentally, we haven't been seeing that the children are deficient in growth hormone. So their body is still making growth hormone. It's not, there are some children who actually are missing growth hormone. And so you have to give them that hormone back. It's like diabetics who are missing insulin. You have to give them insulin back for their body to work. Kiddos in general with Okur Chung syndrome aren't missing the growth hormone. And in general, I haven't seen them being treated with growth hormone, but I have seen across other neurogenetic conditions, you can do a little bit of override. So what I mean by that is, even though you're not completely deficient in hormone, I have seen some individuals that will still sort of top it off and give more growth hormone on top of that. You may get some immediate increase in height, so you can have a growth spurt that comes with that. I don't know that it changes final adult height by very much. I think it probably does give you a little bit, and by a little bit, I mean maybe a couple centimeters or 1.5 inches or so, but I don't think it makes a difference in a foot or 6 inches in terms of that. But the other thing that the growth hormone does is it actually increases your muscle mass. It increases the lean body mass. It increases the muscle mass. And I have seen children where their hypotonia is a little bit improved simply because they have more muscle mass to kind of hold themselves up and hold things together. So I'm not saying that's the reason to do growth hormone, and I don't want to give you unrealistic expectations. It is an injectable medication, so it's not an easy medication, especially for our kiddos to take. And it's an expensive medication that for most countries, most health plans, there are very specific criteria that you have to meet to be able to get growth hormone. And so for the most part, the children won't qualify because they're not growth hormone deficient. But just to answer that question that's been floating out there in the community.
Okay. This is a research question. Are the mice models homozygous for the mutation?
I guess I'll take that question. We have one mouse model with which we're working so far. I've talked about this. It's the 198 mutation, and this is heterozygous for the mutation. So we're modeling exactly how the genetics that are also occurring in patients, because all patients known to date are heterozygous for the mutation. They always have one good copy and one deficient or defective or mutated copy, and that's what we're doing with the mice as well.
So this leads us into the next question, which is, for potential gene therapy, would OCNDS need a therapy where the protein is silenced or a corrected one is introduced into the body?
Yes, silencing wouldn't help. We would want to make that mutated, the allele, the one copy that's not quite correct, we would want to correct that. That's the ideal situation. Whether that can be done easily or not, in humans, that's another question, but we're trying to do things like that in the mouse very soon. Actually, we're making a mouse model right now where we can find out in principle whether changing this, correcting this in later stages of life, so not in the embryo, but later on, whether that can help to basically cure or revert the symptoms, the phenotype of the mice.
And going back to CSNK2A1 gene and CSNK2B gene, there's kind of a two-part question, which is how relevant are each other's syndromes? And then could the researchers study both CSNK2A1 and CSNK2AB, or is it like studying two different completely unrelated genes?
I can take that, and maybe Isabel can join as well. I think, of course, we should and can study both, because as Wendy said before, those two genes are different, but they work together in the cell. When we say CK2, we mean the complex of alpha, A, and beta together working as one enzyme in the cell. So we have a very strong interest in studying both, and we're hoping to also generate a mouse model for the beta condition, for the Poirier syndrome as well, and study that at the same time. But obviously OCNDS is the disease that's maybe more advanced in our research. The mouse model has already been made, etc. So we're working on that, but we're hoping that at some point we can combine working on both mouse models. Mm-hmm. And I think they can learn from each other, just as the humans have an overlapping symptomatology. So we're expecting also that the mice reproduce that, and that they can inform on the other condition. Same for treatment. When we study treatment, it will be good to understand whether both, I'm only speaking about mouse models now, if treating both mouse models will have a similar effect or different effect.
Yeah. And just to add to what Heike said, we typically in the laboratory, we study both of them, mostly because CK2 alpha has been shown that it stabilizes CK2 beta. So wherever you have a lot of CK2 alpha, there is more CK2 beta and the opposite. So typically when we study mouse models or cells in the laboratory, we study both.
We've had this next question come up a lot in our community, which then leads into a few other questions, which is, if someone is diagnosed with OCNDS, is it possible for them also to have an autism diagnosis?
That's a good question. Let me try and disarticulate this. So the OCNDS is defined by the gene, by the genetic condition, and then with that, there are the manifestations, and those manifestations can be different in different people. For some people, it manifests as autism. For some people, it manifests as seizures. For some people, it manifests as problems with growth, and there's a whole list of those things that it can manifest as. Any one person can have some, but no one has everything on that checklist. That's just always the case, that no one, and if you're new to the community, don't freak out that you're gonna end up having at one point or another everything on that list. It's gonna be some subset of those things. For some individuals, I would say it's pretty stable. You know, they stay stable in terms of those things that we see over time. And I don't think it's radically going to change for any one person, but there may be things that evolve. And as I was saying, over puberty in particular, not just epilepsy, but some other behavioral manifestations may change over puberty as well. One of the things that I think is partly sociological, to be honest, is that in the United States, at least, an autism diagnosis can be helpful in some ways to access resources, educational resources, other support resources. And so there are some individuals that's just a more understandable diagnosis. It's something that's more relatable because, you know, Okur Chung syndrome, no one's heard of. I mean, it's like, what's that? I have no idea how to relate to that. I don't know what services your child needs. I don't really understand that. And so diagnoses more like autism, people, they get that, you know, and there's a way in terms of a public school system for a track in terms of what services are then provided. So I think, at least in the United States, it's very commonly the case that we'll give those types of diagnoses to help streamline communication and advocate for resources for our patients.
So leading into our next question then, is my son has been diagnosed with autism spectrum disorder and developmental delay before the OCNDS diagnosis, but not IDD or intellectual disability. At what age and how would you diagnose IDD specifically? This individual's son is 10.
So I'll give a general way of thinking about this. So intellectual disability for us is a definitional thing that when you take an IQ test, if you're sort of low enough, or 2 standard deviations below the mean, then we have a definition of intellectual disability. It's difficult to be able to get accurate measurements on young children, children also who may have other handicaps or other disabilities that just don't allow us to really see what they're able to do. So we have kind of a placeholder diagnosis until that time in terms of neurodevelopmental delay or developmental delay that we use as a placeholder for them. I think the general idea, though, is that all of our kiddos in the community have some level of challenges, some level of brain challenges in terms of how their brain is functioning, how they're understanding, how they're communicating. And I guess I don't get too hung up about the exact terminology in terms of this. I think it's more thinking about the specific areas where they're having challenges and helping them to support them to be the best they can be, in some cases with technological or additional educational supports to be able to do that. So I'm going to call it kind of tomato, tomato, potato, potato. Don't get too hung up in terms of the exact terminology. Just make sure that we can advocate for your child or your family member to make sure that they can get the resources they need.
This is a follow-up on the growth hormone question, which it comes up a lot in our community. Will the muscle mass decrease again once growth hormone is stopped, or will it maintain the increase that you discussed earlier?
So in general, for individuals who take growth hormone supplements, when you stop them, their muscle mass does decrease afterwards. It's not a permanent change that lasts forever. That's true also, not that you guys should be doing this, but with anabolic steroids and other things as well. It's, it's sort of it comes and it goes based on what hormones are in the body stimulating that.
And then this goes to height. Has there been any research conducted with heights of kids ages 0 to 18 with OCNDS?
So we've been collecting that information from everyone. Let me, Jennifer actually referred to this very briefly in her introduction, and let me reinforce that the reason we're going through all this rigmarole with the natural history study is to try and get, I would call them growth curves. So literally the way we have growth curves for regular children, we need growth curves that are specific for our community so that we know in terms of whether or not kids are on target. We need them to be age specific so that we know by age and by sex what a target appropriate height is. So that's one sort of growth curve. We want developmental growth curves, and that's what we've been doing and what I showed in my talk in terms of when we expect children to be hitting certain milestones over time, and to help set expectations for what we think our kiddos can be able to do. And then the third, I would say, and this is all part of the same thing, is what I would call standards of care. It's really important to be able to say, this is not just for you as families, but for the entire medical field around the world, to say, this is what you should be screening for, this is what you should be monitoring, these are best practices in terms of interventions that we think work, and then be able to give guidance to doctors who take care of your children, and for payers, for insurance company or government payers to pay for the care that you need, because there's evidence to back it up, and the evidence is coming from you. So one of the ways that we do this is to do things, there's something online called gene reviews, which is an easy way for us to be able to have even standards of care, or it's kind of like a standard of care that we can update pretty readily and make it free, make it accessible to everyone all over the world. And that's one of the ways that we do this to support the community. So anyway, we'll be working with you. We are trying to get to that point. I feel like we're a little bit shy, a little bit short on the evidence to be able to make some sort of bold proclamations about what we should be doing. Numbers, for instance, like 100 get doctors sort of more confident that what we're saying has some validity. So that's how we're hoping to do this, both from cases in the literature, cases coming from Simon Searchlight, wherever we can gather the data, but to put it all together.
And I think you kind of covered this already, but just to be very clear, is there any chance that some OCNDS symptoms will develop over time?
Yeah, I think in our kiddos, again, I'll also say all bets are off for me in terms of what happens when folks are in their 30s, 40s, 50s, 60s. I just think we have no information at that point. The most dynamic periods of change in general across the board are during adolescence. It's just, things are changing, hormones are changing, behaviors are changing with that. So I'd say that's one dynamic phase that I don't know that we've completely understood yet. And then I would just say there are also, in terms of other major medical issues, it's just harder to be able to get back on track. So if there's something that disrupts because there's, an illness or because of a bad case of the flu or whatever it is, it's just harder to get back to where you were before. And so I do think we see some of those changes during adolescence. Another just physical change that happens sometimes is scoliosis, or curvature of the spine, which is also related to that hypotonia, that truncal hypotonia that we see. And hopefully that's something that's caught early and we can keep the spine straight without, for instance, needing surgery. Because surgery for our kiddos, it's no joke if you have to have spinal surgery for anyone, but especially one of our kiddos. It just takes a bigger toll.
And the next question is regarding toileting. This comes up a lot in our community. We have parents that are frustrated. And how can you tell when a child is ready for toileting? How can you tell if his body is ready for it? And this comes from someone with a 5-year-old.
I'll start this, and then if anyone else wants to chime in, feel free. I know it's frustrating, and it's just such a practical thing in terms of programs your child can be in, what you can do on a day-to-day basis, being out and about, and I totally get that. For me, the first thing is just awareness, in terms of awareness for the child of what their body's doing. If they're wearing a pull-up, realizing they at least pooped in their pants, or they have a wet diaper or a wet pull-up. I mean, that's kind of the first stage to awareness that things are going on, and that's a good sign. There are all sorts of tricks, and we've done it before, and we can maybe even after this point back to the library that we have on toilet training, and some of my Simon Searchlight team can help us in terms of digging that up. A lot of it to me is then about, it's partially training you as a parent to work with your child, even more so than training your child. So it's getting into the habit of having a toilet seat that they feel comfortable on, they feel stable, they can put their feet on the ground, they don't feel like they're going to fall off or fall in. So as you've got that set up, as you do, just sitting down at multiple times per day. So, it could be every 2 hours for going, number one, or, urinating. And then depending on when your child, and if your child is regular, trying to think of those times when your child, because when you're changing them, when they're likely to go, and putting them on the toilet at that time. So it's kind of training you even more than you're training the child initially. And as they get used to that, it's hard to do, but it has to be a team effort. So if your child is going to school, and I know this is hard sometimes, it's making sure that whoever's at home and whoever's at school, and it's weekend and weekday, keeping that pattern very, very consistent so that everyone's on board with doing the same thing all the time. And there are going to be accidents, and you just have to accept that things aren't perfect as this happens. Nighttime accidents, daytime accidents, but you praise, you focus on the good things, and you praise for when things do go well and things do, go as scheduled. I know it's frustrating, and I know, like I said, depending on whether your child also has problems with constipation or diarrhea, it's double trouble. It's not just with the toileting and being able to go on time, it's that, things just are not predictable with the tummy in general.
We want to thank all of our community for participating. We have time for about 2 more questions. There are more questions than we can answer. The next question is, with regards to the possible increase in attention issues as children get older, what effect does intellectual disability have on attention, especially with mild or milder intellectual disability, the gap between what my child is able to do compared to other children her age? Would this also show up as issues following and holding attention, or is it separate?
So I'll say personally, I think attention is part of this. So I think in terms of the attention span is shorter, and as the attention span is shorter, it's harder to learn. And so you do have to think about educational strategies where you're doing things in smaller bites. So whether these are 10 to 20 minutes, but it's definitely not an hour in terms of putting all of this together. The biggest thing that people notice, which I think came up in the question, is that there's a bigger and bigger gap as time goes on. So as kiddos get older, that it just becomes more noticeable. They're still making forward progress. I don't think they're plateauing in terms of, as long as their teachers aren't plateauing and giving up on them, I still think they can continue to develop additional skills. It's just that it becomes more pronounced and more obvious as people are starting to go on to, do math and, doing, being more independent with things. I think it's really a matter also of, I know I say this all the time, but focusing on what matters. So things that are very practical, that, are functional in day-to-day life, allow for more independence. It's focusing on those things, and it all depends on how your family functions, exactly what those top 10 things are for you to be able to prioritize within your learning system.
And I think this next question reiterates a little bit of what you just touched on, but is it likely that cognitive development will halt or plateau during childhood? I have heard from some families with older OCNDS relatives who are young adults that their mental age stopped developing during childhood, so they have a mental age of about 8.
So again, it's a little hard for us to see because we don't have so many repeated measures, being able to see people over time where we can directly see this. I don't think 8 is far off in terms of, like, I don't think our kids are developing to being a mental age of 16 or 18. So I want to be realistic in terms of setting those goals and expectations. I do think that as there are new technologies, though, one of the things I think of it as a multiplier or a way of augmenting, that there are a lot of technologies that are now available for someone to be able to effectively do more, even beyond what might have been sort of a mental age of 8-10 years ago. There are just more ways than to skin a cat, so to speak, you know, more ways to be able to get things done, and whether it's with communication or whether it's, you know, other things. So, you know, don't put an artificial cap on, keep supporting your child in terms of being able to move things forward. And I think I've been very guilty of it in the past, you know, not appreciating how much our kiddos understood and were really processing and understanding until they had some of the new technologies to be able to communicate better.
I know that the screen is going to cut off right at 1:15, so I wanted to thank everyone for joining this Q&A session. I know it went too quickly. I think we have 20 plus questions left to answer, so we'll figure out a time that maybe we can do this again. We appreciate how interactive our community is, and we hope that you learned some valuable information from the speakers. I want to thank each and every one of our speakers and panelists here today for participating in the Q&A, and just the time and your hard work and your efforts that you give to give our children a better life.